Okay, thanks, Rupert, for having me. It's great to join you guys. So, yeah, it's be really fun to discuss this paper we recently published. Is the second case series that we've published from our clinic here at the VA. And this work was first authored by Stephen Pennybaker, who's a now graduated psychiatry resident. He helped out with it. I just want to make sure I give him some credit. So what I'd like to do is, if this is going to cooperate, there we go. Just give you a real quick overview of our ketamine clinic, which we've been running here for a number of years and have, I think, over time developed a fair amount of experience with this modality. A little bit about the research we're doing. And then what I'd like to do is set the stage a little bit for how we came to get interested in doing these case series. Specifically, what I think are really potentially the power of looking at this real world outcome data, which I imagine many of us are collecting, not just in terms of providing us the framework to optimize treatment in the clinic, which is very important, but also I think there's a real interplay with our colleagues doing more mechanistic work that might be a homage to my more mechanistic research background. And we'll talk about that a little bit. Briefly about some of the potential mechanisms of ketamine and why we thought age might be an interesting demographic variable to consider in looking at these treatment trajectories. And then we can go through the figures in the paper. Okay, so I won't belabor, but I started this clinic about 4 years ago with a number of colleagues here at the VA. Really, with none of us actually knew anything about how to do this, so it was an interesting time. And actually, that's the year that the rather tepid APA consensus guidelines came out in the American Journal of Psychiatry. So that was also an interesting time to start doing this clinically. But in the 4 years, we've accrued quite a bit of experience. We've treated almost 100 veterans, give or take. So, several thousand infusions under our belt. We've developed a residency training, like we've trained a number of residents in this. We have a research program. Our clinic is currently still in the post-operative care unit, which you see on the bottom right there. I think this is similar when I've heard Rupert speak in the past, kind of a similar arrangement. So we have our infusions going. Actually, that little blue drawer in the corner is our ECT cart. So we're kind of doing ECTs concurrently with the IV ketamine and other bays. Not an ideal space. And actually, it's been a very long and hard slog, as you can imagine, in a government bureaucracy, but they did finally complete building us a freestanding IV ketamine clinic, which we will move into, unfortunately, after I've left here, but it's nice to see that I could kind of get that launched as well. Our clinic here at the VA, just to set the stage, as we would imagine, it's a largely male population. Here at San Francisco VA, also relatively older, so we tend to have more of a 50s and up population, less of the younger vets. We really reserve this treatment and still do for, operational, I think initially for being conservative because it is an off-label use of ketamine. And as we've gotten more comfortable with the modality, really just to conserve limited resources, we really have reserved this for chronic and severe depressed treatment-resistant patients with or without PTSD. And I've been really careful about that. So we'll look at the demographics in the paper, but we really try to reserve this for the most resistant folks that have, really the sickest patients on the service, of which we unfortunately have a lot at the VA. Our clinical protocol, which has, I think, gotten a little looser over time as we've gotten more comfortable with this and generated our own internal data. And of course, I think a lot of the initial concerns about ketamine toxicity that were brewing in 2017 are looking more promising. I don't know that we have, 100% reassuring answers, but certainly better than we were. But, we operate in the real world here. So so no active substance use for 30 days. We're flexible about cannabis use because we are in California. We wouldn't have any patients otherwise. Obviously, we want people's hypertension to be under control. We really don't like treating patients with psychotic disorders. Of course, psychotic disorders exist on a spectrum. So, everything has some flexibility around it. But that's really about it in terms of our exclusion criteria. Inclusion criteria would be severe depression or severe depression and PTSD. Our protocol, which is, I imagine, what many folks are doing still that are trying to hew as best we can to the existing evidence base, which is obviously very limited for multi-infusions. But we do a 6-infusion protocol every 3 weeks, so twice weekly for 3 weeks. We start every 1.5 mg per kilo over 40 minutes. So this is all just kind of bread and butter IV ketamine clinic. In the last, I'd say 2 years, we've gotten more comfortable delving into this flexible dosing paradigms, which we do cautiously between 0.5 and 1 mg per kilo. And I'd love to hear people's input on dosing. It's sort of, I think, the next big question we need to tackle. And then, as I think we've all found phenomenologically, but really lack any solid evidence base, would be a great case series if someone had the data. Good data to do would be what happens in maintenance. And I think what we found and others have found is that people are then coming in about every 3 or so weeks for a booster infusion. So that's kind of, generally speaking, been how we operate. So, what got me interested in doing these case series originally, I think really 2 things. One is, well, we're here collecting this data clinically, and there's a huge parameter space that we all need to sort out with how to do, particularly multi-infusion ketamine series. How can we optimize these treatments? But the other piece is, maybe it's coming from my more mechanistic background, is that I really think there is an important role for real-world case series data in essentially providing a hypothesis generating mechanism that we can then pass to our colleagues with the grants and laboratories to do more mechanistic studies. So there's an important interplay that I think we don't always appreciate. And I think there are really 2 big questions that got me excited, and I think are the big issues, in my view, that we should be trying to tackle in terms of sorting out both parameter space and mechanisms. Once we start talking about these multi-infusion treatments, which is what I would imagine most people are doing clinically that are doing this, we start thinking about, well, what's that trajectory of response over the infusions look like? How can we optimize or individualize treatment planning? Some of these issues are really elemental and still not sorted out. I mean, we do 6 infusions because we work at a government hospital. We want to try to color between the lines as best we can. And it so happens there are a number of small RCTs that looked at 6 infusions. But is that the ideal number? Should it be 8 infusions, 10 infusions? Should you taper? Right, there's a lot to sort out. There should some patients get more than 6. Who are those patients? Dosing, we're not going to talk about in great detail in this talk, but that's a whole nother question. Is half mg per kilo perfect for everyone? Probably not, but we also want to be thoughtful about giving people higher doses of this drug, right? And then I think getting into demographic characteristics that might interplay with treatment trajectories, right? So what are the mediators and moderators of response? We're going to look at age today, but certainly, psychiatric comorbidities, concurrent medications, all sorts of questions like this, concurrent substance use disorders. How can we bring that to bear to help us come up with a better treatment algorithm? And then again, I think better understanding of these demographic details, mediators and moderators will provide the kinds of opportunities then to develop hypotheses about mechanisms. And as we'll see today, and this is, again, you have to be careful, of course, trying to make any big statements about mechanism from a case series, and I'll be very cautious about that. But I think I could give you a sense of where I'm at and thinking about, there could actually be could be a multi-mechanism process over the course of treatment. That's sort of what I'm thinking right now. I could be wrong. The other big issue, which I think we would all agree, anyone doing this work in any way you're delivering, whether it's intranasal, IM, IV, is that the big Achilles heel of ketamine as an antidepressant is its clinical durability, right? This results in bandwidth problems for the clinic. It's highly costly, right? People come in the clinic, you can't really move new patients in. So we need to extend ketamine's antidepressant durability. It's really the critical question. And we can start by just looking at the data we have from the clinic. Are there any clinical predictors that we already might be able to pull from our case series that suggest patient characteristics that might lead to better or worse durability? And how could that help, again, our colleagues doing more mechanistic work to come up with ways that we could either improve ketamine as a drug or give augmenting agents that could help extend durability. So when I started looking at our data, and that's on the right side here, this is actually figure, I think, 1A from the paper, which is this 49 veteran case series. So the first 49 veterans we treated with 6 serial ketamine infusions. So there's a couple things that pop out at me. So what you see is the Beck depression inventory here on the y-axis, and then ketamine infusion number, and then at 3 weeks is the 3-week follow-up. So when they come in 3 weeks later for their first booster infusion. And what's always popped out to me is that at a population level, you see this relatively large response to the first infusion, and then a slower evolving response over the subsequent infusions. And then there's some extent of symptomatic relapse 3 weeks later, but not nearly to where people were. And I think you find this just subjectively talking to patients, right? And this fits the pattern from other papers. So this is actually a case series paper out of Minneapolis VA, Paula Schroma's group, looking at veterans again, similar kind of deal, right? There's sort of an immediate quick response and a slower evolving response on the Montgomery from 6 infusions. This is actually one of the, I think maybe the earliest 6 infusion paper from Mount Sinai. Here they broke it out with responders and non-responders, but even with responders in black, you see that, clearly there's continued improvement here from here to here, for example, so over the 6 infusion course. So something's happening relatively quickly, something's evolving more slowly with subsequent infusions, and then you have this question of durability. And then when I started looking and just playing around with our data, this is actually some years ago, another thing that was interesting, and we found this subjectively first, which is why I looked, which is that you had different kinds of patients in the clinic, and I think many of you have probably seen this. You had these sort of what I would call canonical responders, people you get one infusion, have these dramatic responses to one infusion, and are extremely pleased and do great. You have these sort of weird delayed responder folks. So, they're coming in, they're out at infusion number 2 or 3, and they really haven't gotten anywhere. Then something dramatic happens after that infusion. So that's kind of weird. And then we have what I think I'm seeing more and more commonly for whatever reason in our clinic, which is these slow and steady types, right? So they just, they keep getting a little better, a little better, a little better over the 3-week infusion period. And so what is it about these different kinds of phenomenology? Like what's driving that? What can we learn potentially about mechanism, or even just frankly clinically, so we can give people optimal care about these different kinds of responders. Okay, so how did we land on age as a potentially interesting demographic variable to look at in our data? Well, just quickly, I think there's a few different possible mechanisms for ketamine antidepressant effects that are floating around. Probably the closest thing to a canonical mechanism is this idea with the antagonism of the NMDA receptor, preferentially on GABAergic interneurons over the glutamatergic neurons. And so the result is you get kind of an inhibition of the inhibitory circuits, which leads to a sort of release of the brake on the glutamatergic circuit. You get this glutamate surge and long-term potentiation. This is a very directly plasticity-based mechanism. Nolan Williams and colleagues came out sort of somewhat surprisingly several years ago now with this opioid idea. So they gave naltrexone to patients in a single infusion and attenuated its effects. So they were saying, well, maybe the opioidergic activity of ketamine is what's key. And then there's this, and I'm not saying these are the only 3 possible mechanisms, but there was a recently interesting paper in Molecular Psychiatry that came out actually suggesting, at least in an animal model, that ketamine, in fact, is blocking excess glutamate. So instead of causing a glutamate surge, you're actually blocking a glutamate surge. And we know from postmortem data and other sorts of data that at least in some brain regions, major depressive disorders associated with excess glutamate, and that when in this preclinical model, they were able to actually block, ketamine was blocking the excess release of glutamate presynaptically, and that was actually what was antidepressant. So interesting. Now, we know that at least with respect to the first mechanism, plasticity mechanisms, long-term potentiations are attenuated with older age. Lots of preclinical data on this, as well as human electrophysiological data. Interestingly, perhaps even if you think about the excess glutamate hypothesis, generally speaking, AMPA, so the non-LTP-related glutamate mechanisms are also attenuated with older age. So the glutamate system in general is tuned down with older age. So as ketamine interacts directly with that system, we think in doing what it does, you could imagine that older folks might have a less robust interaction. Their receptors might either have less receptors or less robust interaction with ketamine. And we have some clinical data to point us in this direction. Now that there really hasn't been a lot of work on looking at what we looked at here, there's a few very small case series looking at single infusions that are kind of mixed, mostly showing no effective age on ketamine response. The Wilkinson did actually do sort of a broad analysis of their case series data at Yale some years ago, and age was one thing they looked at in that case series, and they did not find any interaction of age with efficacy. Now, what they were doing is a little different than us. They had sort of a range of infusion number from 1 to 4 infusions. They weren't looking at veterans, which is always a different story. So certainly, though, worth noting that a similarly powered case series did not find this. And then the other thing that kind of got me pointing this direction was the Transform-3 trial from the Spravato data, the intranasal S-ketamine data. So this was Janssen's attempt to get FDA indication for Spravato for geriatric depression, so patients over 65. And they looked at their the effect of esketamine at a 4-week endpoint versus placebo. And so they didn't find any separation from placebo, though you can see actually it starts to separate, but just doesn't quite make it. It almost looks like if they had done a 6-week endpoint, maybe they would have gotten there. What was interesting, though, about this, and I'm not sure if they published this or just what Jerry Sanacor told me, I can't remember. I think it's somewhere in a supplement, actually. But when they did a post hoc analysis in this data, the younger of the older patients, so the 64 to 74 group, actually did meet endpoints. So this attenuated response here was really driven by the 74s and up. So again, suggesting that that age did slow the response to esketamine, but maybe did not completely block it. And maybe with a 6 or 8 week endpoint, they would have separated. Interesting. Okay, so let's jump right into the paper. So our goal here was to examine age, or our hypothesis is that age would be a moderator of response to 6 serial ketamine infusions and durability at the 3-week time point when they come back in. And so that's what we were looking at there. And we ran a mixed linear model examining the interaction of age with time in this case being infusion number. And we're looking at percent change in BDI. So for each time point, the percent change from baseline BDI for that patient, sort of attempt to normalize things. And then we did sort of more of a standard correlation to look at the durability, so the percent change in the Beck from infusion number 6 to the 3-week follow-up. I should say this is real-world case series data, so some things are certainly not ideal. I'll be the first to acknowledge that. The first being that due to clinical operations limitations, the Becks are being collected prior to each infusion. So we're not really, unfortunately, collecting the acute 2-hour, 6-hour, even 24-hour effects of each infusion. The other reason it's important in our analysis is that when you see the Beck at infusion 6, that's the Beck collected before infusion 6. So we don't actually have the Beck for the effects of infusion 6. So it's a little bit unideal in that sense. And then likewise at the 3-week follow-up, you're getting the Beck just prior to that maintenance infusion. Okay, well, we touched on demographics a little bit, but worth reviewing again. Again, we were doing the 6 infusion protocol. Almost everyone got half mg per kilo over 40 minutes. This case series started to bleed into when we started playing around a bit with dose titration. So we did have 7 patients that got slightly higher doses. We reran all analyses with those 7 removed to make sure that we weren't, just this whole thing was actually an artifact of those 7 patients getting higher doses, and we got the same outcomes actually. Again, no substance use for 30 days, uncontrolled hypertension, no psychotic patients in this case series. And we did have some attrition because particularly early on in the clinic, we were treating a higher number of inpatients, and some of those folks didn't follow up. So when we're looking at the 3-week follow-up, it's a subset, unfortunately, of the total 49. So our patients here, again, median age is 50, 3/4 male, so it's a standard VA story, about a third having comorbid PTSD, and I would say severe PTSD. We had a few bipolars in the group. And I think other important thing to note here is that this is an ultra treatment resistant group. So the average number of failed antidepressant trials is 9. And about a third have had prior ECT. And I'd say either were ECT failures or perhaps more commonly were partial responders, but had a high burden of cognitive side effects. So it's kind of like the treatment was sort of working, but there was just a high side effect burden. Real world data. So folks continue their medications and they're on all the sorts of medications you would imagine folks with extremely treatment resistant depression might be on. We did have a few folks on lamotrigine, which can give reviewers heartburn because there's some idea that lamotrigine might interplay with dissociation. So we also, in a subsequent analysis, removed our lamotrigine patients from the group and reran everything. It didn't affect anything. But, I think there's a whole nother difficult analysis to do to try to parse out the effects of these different medications. And of course, then they're in combinations and augmentation strategies. So it all gets very, very headache inducing rather quickly. Okay, so I think we already looked at this figure, but this just gives you, again, a sense of how things evolved for this cohort of patients. So the average Beck starting out was 35.5, and by the 6th infusion, we had dropped about 20 points. So pretty robust responses at the population level, and then a partial, at a group level, again, a partial relapse of symptoms by week 3, but certainly nowhere to the extent where things were at the beginning. To look at this as percent change in baseline, And I think what's notable here is that sort of 30% of the total effects occurring from infusion 1, right? And then you kind of have the remaining 60% evolving more slowly over the subsequent infusions, which is interesting. And okay. Okay. So let's get to the meat of it here. So we, our very talented biostatistician did this for us, ever to his debt. We ran our linear mixed model and looking at age by time interaction, which was significant. So time, again, being infusion number. You can see the relationships here on the left between age on the y-axis. This is decimated percent change, so percent change in Beck from baseline, and then infusion number here is along the top. And as you can see, is that as you march through these infusions, the importance of age becomes more important, at least towards the middle here, infusion 4 and 5. So the older folks having less robust responses later in the treatment series than the younger folks. And then things seem to even out a bit at the end. What we found was that there was a statistically significant effect of time, age and time at infusion 4, so with the p-value 0.04, and a trend towards significant at infusion 5, which, pretty good for a case series of 49 patients. And then when you get to infusion 6, again, not these 6, the effect of the 6 infusion, but at infusion 6, that relationship seems to be flattening out again. I think a helpful way to look at, I'll show you the raw data in a minute from our supplement, but I think this is a nice visualization. So this is actually model generated data. So you kind of have your model, then the model can spit out model data for you. And so this is a nice representation of what we found here on the right by age quartiles. And so 0 is where everyone's starting up here. I think a couple of things are notable, right? There doesn't seem to be any effective age on the effect of the first couple infusions. Everyone's running together, but things start to separate out here at infusion 4 and 5 and before they kind of come back together again. So again, your younger folks have these kind of more rapid responses and flatten out, whereas the older folks are kind of needing to hang in there and have these more slower and gradual responses. Now, everyone did seem to come back together here at the end. I don't know if that is a function of power. It could be, and we should probably do this, now that we have more patients, see if this actually would continue to separate, which is important because it would suggest, in fact, if they did continue to separate by age, that older folks need more infusions potentially than younger folks. But at least our data would suggest that they all end where they started. And so what the model predicts is that for every decade increase in age corresponds to about a 9% less reduction in the Beck at infusion 4. The raw data, and this is again, these quatriles. So the cut point here between the second and third would be mid 50s. It's interesting that actually in the raw data, it seems like the over 55s and the younger 55s are separated out a bit more than you might imagine. It also looks to me perhaps that with more power, we might continue to see this separation out of the later infusion, which the model didn't show, but it could have been a power issue. We'd have to see how that looks, but that's just to give you kind of the real data. So I'm not just showing you beautiful modeled data. Okay. Interestingly, then we looked at, well, what's the impact of age on durability, right? So this is more of a standard correlation. We took the percent change in the Beck from that 6th infusion to the 3-week follow-up. And we found really very much no interplay between age and durability at the 3-week time point, which was interesting. Okay, so there were some other factors, of course, that we looked at. One was sex. So we did rerun our model with sex as a covariate, and there was a significant main effect of sex, but that age by time interaction remains significant as well. We were able to remove the females from the group because there just weren't as many. We still had enough power to just run the males, and we continue to find the same pattern of effects. Actually, interestingly now, infusion 5 became statistically significant with just the males. So that's sort of interesting. We weren't able to do the inverse because I think we only had 14 females. It just wouldn't be enough power to rerun the model with that. But it would be interesting to look at to what extent gender might be, or sex, I should say, might be interplaying here. We looked at BMI. So there's some prior work with single infusions showing that higher BMI patients have more robust ketamine antidepressant responses than lower BMI patients. Now, I think an important point with those studies is that they were doing just standard weight-based dosing. We actually do, and I should have said this earlier, we do adjusted dosing. So this is sort of standard infusion medicine. As your BMI goes up, but you're doing an acute infusion, you're not really want to necessarily account for all of the extra adipose tissue the ketamine's not going into in 40 minutes in a way that significantly would, affect receptor binding in the brain. And so we were doing weight adjusted dosing. And actually, so we did not find, well, we did actually find effective BMI, but it was the inverse effect. so sort of interesting there. Again, we had a few folks at 0.6 and one at 0.7 mg per kilo. So we pulled those folks and reran everything and found the same outcomes. Medications are always an issue and kind of a mess, particularly with the, relatively small in the grand scheme of things case series. So we weren't really powered to address that. We did pull the 3, I think actually it was lamictal patients, but we didn't have any impact on our outcomes. Okay. So what does it all mean? So, I think kind of to bring it back to where I started, from a clinical standpoint, I think we've started to advise older patients of this in the clinic. It may be, in fact, the case that older patients respond more slowly to serial ketamine infusions than younger patients. So that could mean 2 things. One, I think one might advise an older patient not to be discouraged if they're coming in after 1 or 2 infusions and haven't felt a gangbusters response. It's not a reason to give up. It could mean that they should get more than 6 infusions. I don't think we can say that from this study, but it kind of makes sense clinically to me. So if I have someone in the clinic who's really not budging, say a 70-year-old patient where finally starts to get some relief around infusion 4 of 6, I might feel just clinically it's appropriate to tack a couple more on the end just to see if we can really make sure we've gotten our maximal clinical response from the induction series. So I think we've done that at times. And then I think the other takeaway is that, well, age doesn't seem to have much to do with durability. Something does, and it would be sure nice to figure out what, but it's not age. So that's another thing we can advise our patients. Now, what about the mechanistic implications of all this? Well, and I have a nice little picture I'll show you in a minute, but it suggests to me that there could be different things going on in kind of the early part of a serial ketamine treatment versus the later infusions. And maybe this breaks down to maybe the early infusions are more opioidergic mediated and plasticity mechanisms predominate later where age seems to moderate. And we could hypothesize relatively safely that age and plasticity are linked. There have been a few interesting pharmacology studies that might help us here. So one is this drug D-cycloserine, it's an old TB drug, but it turns out D-cycloserine is also a partial agonist at the glycine binding site of the NMDA receptor and has been shown in preclinical and in human neuroscience studies to have a pro-plasticity effect. So kind of like a little bit like we think ketamine might work. So there's been some attempt to extend ketamine's antidepressant durability using D-cycloserine, again, single infusion studies, which did not work. Riluzole is another ketamine modulator that's been looked at as sort of a ketamine-like analog that also did not extend ketamine's durability from single infusion studies. There's a really interesting study out of John Crystal's group last year that is confusing. And in this study, they gave people rapamycin. Rapamycin's a immune modulator for transplant medicine, actually. But what it does is it inhibits this downstream signaling molecule called mTORC1. And mTORC1 is thought to be a key downstream signaling piece in the ketamine response. And so what they were actually trying to do was to see if rapamycin would block ketamine's antidepressant effects and sort of have a proof of function kind of study. And they did not find that. And in fact, what they found, strangely enough, was that rapamycin did extend ketamine's antidepressant durability, but did not impact its efficacy. Very weird. I don't have an explanation for that, but it suggests there's then something different going on with durability than treatment response. So again, I put this up cautiously. I'm not making any bold statements about what's going on, but I think these are all interesting questions for further mechanistic study. So a possibility is that to the first infusion, perhaps we have mechanisms at play that are not as impacted by age, such as potentially opioid-based mechanisms, or maybe other mechanisms. And then maybe it takes a little while for more plasticity-based ketamine mechanisms to kick in for whatever reason. And so we have more age-moderated mechanisms that are predominating over the latter part of the infusion series. And maybe that partly explains the difference on the slopes here as well. I don't know. And then perhaps durability is yet a third, kind of mechanism that we need to think about. Maybe that's opioid-based, something to do with mTORC signaling. Maybe it's a story about long-acting metabolites. This is really just more of a metabolomics story than something fancy in the brain. So that's kind of how I've been thinking about this. And I think there's some interesting footholds here for digging in with some preclinical and clinical mechanistic studies to try to parse this out. And just want to thank all the folks that helped me with this. Of course, Stephen Pennybaker is the first author. Art Wallace, the chief of anesthesia here at the VA, has been my primary collaborator, and everyone else who helped us. That is indeed the San Francisco VA sitting on a bluff over looking at the Golden Gate Bridge. And I'll be happy to take questions.
Thanks very much indeed. Is it Toby or Tobias?
Toby's fine.
Toby. That's terrific, and I really like the way that you're thinking about what this might mean, always trying to tease out what it might mean for mechanisms. And I remember sort of talking to people about how ECT might work. There seems to be this acute effect, and then the effect builds. Is that neurotransmitters and neuroplasticity, or dentate gyrus, hippocampal cell division, or whatever it is? They're two distinct mechanisms. And I'd like to invite everybody to submit their questions. We've got a couple in chat and one in the Q&A. If you could actually submit your questions through Q&A, that will help us just to keep it on track. And I'm sure there will be a lot of questions. So, as I said right at the outset, what we'll be doing in just a few minutes is really moving over to more of a meeting and bringing everybody over as panelists. So I think that we'll keep the questions at this point, if we can, focused on the paper, rather than the sort of more speculative sort of questions. Those are, of course, more fun. But there's a question that Tiago's got, is a little bit more detail about how you adjusted the dose to the BMI.
Right. Yes.
I didn't quite get that either.
Yeah. Thank you. So, I'm looking. I want to make sure I say this all correctly. So there's a adjustment you can do that they do in infusion medicine for the BMI. And I should have been more specific, for people with BMI over 30. So this doesn't affect non-obese patients, but once the BMI is over 30, as I understand it, for certain kinds of infusions, the concern is that you kind of have the amount of drug in the vascular space, but then you have a large amount of fat, essentially, that may not be relevant for an acute infusion, right? And so what folks in infusion medicine do is they apply a formula. So you calculate the person's ideal body weight, which is based on their height, and something I can't remember right. Yeah, there's a formula for that as well. So you get their ideal body weight, and then you add a multiplier of their actual body weight minus their ideal body weight. And so this gives you their adjusted body weight, which is lower than their actual body weight for folks over a BMI over 30. And so this is a way to, again, try to make sure that you're not effectively overdosing someone who is on the obese side. So if you gave someone with a BMI of 32 half mg per kilo versus someone with a BMI of 27, the concern is effectively the person with the BMI of 32 is getting more ketamine into their brain due to redistribution of the drug into fat. Does that make sense? And I'm probably not saying this exactly because I'm not an anesthesiologist, but that's the rationale.
Yeah, if anybody's got a reference for the sort of ideal body weight formula and they want to put it in the chat, that would be great.
Perfect.
And then Tiago's also asked, obviously older patients use more medicines. Do you think that might be a confounder here?
It would be worth looking at. I would say, I don't know that we looked at the interaction between medication number and age, to be fair. So that might be worth doing. I would say that our specific ketamine population here, regardless of age, is so incredibly treatment resistant, and all of them are on a high burden of medications. I mean, I can just kind of say that subjectively. So I could see that kind of outside the VA and outside this clinic where we've really reserved this as almost like a, almost past ECT level intervention. But it probably is, it's a fair idea to look at that. Medication number also gets it gets hard to parse this, right? Like, well, I mean, the number might be important, but it could also be what the specific meds are. So it's been a little tricky for me to think about how to do that in a way that would make sense, particularly with a smaller number, 49 patients, a lot.
Need a bigger data set, yeah.
Yeah.
There's a question from Brian Kerr. Did the patients have any other psychological input, therapists talking, or are they allowed to listen to music during the infusion, or are they quiet? Can you just say a bit about the environment?
Yeah. So as you saw from the picture, the environment is far from ideal, but we do our best with that. So we pull the curtains, try to lower the lights. I definitely encourage people to bring music. I would say almost all of them bring their own music. And if they don't have that, we have noise canceling headphones. So we try to create a low stimulus environment. We're not really in the position in that setting to do any, simultaneous kind of guided therapy. It's a busy PACU. That's something we could futz around with in the new space.
Can you say just how many bays are there in this PACU?
Just roughly 7 or 8, something like that.
8, right? Okay.
We try to shoehorn in there in the morning before the surgery start rolling back. So we have a kind of a 2-hour window from 8 to 10 where it's pretty quiet, and that's when we try to do these treatments.
And how many ECT would you have alongside, on a typical?
Well, it used to be more. And I would say ketamine's really cannibalized our ECT service. That said, there are patients that need ECT and not ketamine, but I would say that our ECT clinics now ended up subspecializing more in patients with psychotic depression and schizoaffective disorder than because we've just had a lot of success with ketamine. So not as much ECT as we used to do.
Okay, thank you. We've had a question, just a comment here. Let's just a bit more on the ideal body weight issue. So somebody who's anonymous says, I believe the original studies showed that higher BMI and more robust response. So obviously they're getting a bigger dose, and that those studies were not actually doing the corrected weight. So perhaps this suggests we actually need higher milligram per kilogram goals.
Yeah, right. Fair point.
A fact and a sort of imputation there, isn't there? Or an inference, rather.
I think the dosing question is super fascinating. I'd be happy to talk about that more. We can
come back to that perhaps. Okay. And Ramesh says, it makes an interesting sort of suggestion here. Is S-ketamine being a dual compartment drug, does that raise the question on the onset of activity? So I don't know whether Ramesh is suggesting that if dual compartment drug would explain a rapid and a slow action. Do you think that that's possible within the time frames that you're talking about?
Well, what do you mean by dual compartment? Do you mean like intranasal and then it gets into the brain directly?
Well, if it goes one direct route and one, via a fat compartment, for example. So there's one acute and one takes longer, it goes into another compartment and then seeps out more slowly from that compartment.
Right. Yeah, that could be. I guess I would. That could explain. I mean, that could be something to look at, right? I mean, maybe a lot of this is a metabolite story, as I said. Though, I guess the question would be, if you're talking about intranasal S-ketamine, is the durability of that very different than infusions once you get into maintenance? Maybe not. I don't know what other people's experience are. I think
we'll come to that. If I can just make a comment though, I would have thought though, if you've got these two compartments, that's going to influence what happens over the order of hours rather than days. So it would be hard. Right. That could account for the two mechanisms for the initial slope and the slower slope later.
Yeah.
Maybe we'll come back to that.